So that begs the question, maybe, Raoul, you can answer. How do you distinguish what's a fit enough adult patient?
Well, that's a difficult question. It's a good question, but a difficult question. There are scoring system and comorbidity indices we can use. They're often used for transplant. But sometimes, as in AML and in ALL, sometimes the patient is sick because of the disease, because of the ALL. Treating the patients or preventing intensive therapy just because the patient is unfit because of the disease, it's sometimes not the best option to do. I think it's a combination of the performance status, ECOG or Karnofsky, the clinical impression the patient makes when he presents, as well as the organ function. So I think it's really a clinical judgment at the end, despite some scores and things we can objectively determine.
So you brought up the concept of transplantation. So I'd like to ask Mark, so who does go to transplant? Which pH negative patient or high-risk patient would be considered for transplantation today in the standard adult patient population?
I would consider any patient with pH negative ALL who has high-risk features to be a potential candidate for transplant. I would take into account their comorbidity scores, but would strongly consider transplant in any high-risk patient that gets into remission, or if they achieve a hematologic remission but are still MRD positive, then those patients definitely would be considered for a transplant. So the short answer would be, I think I would consider all these patients for transplant. One has to take into account, again, their comorbidities, their disease status, and the availability of a donor, and what the potential risk with a transplant would be.
So I'd like to ask Dan, since the Sloan Kettering, what's your experience and how you starting to differentiate?
So I think I agree with Mark that the studies showing, most studies showing that allotransplant in high risk is better, although the largest studies show the opposite, but I think it's still agreed upon. The question is, there's two questions. First, would it be necessary when pediatric approaches are used in at least AY, young patients up to age 40, shouldn't we say very high-risk patients? And I'm not sure what is exactly the criteria. It's 100,000 white cells, so very high, because the cure rates are quite high, and the mortality from transplant may balance negatively the overall survival. So that's one point. Then as you get into older patients where we don't use the pediatric protocols, then you have a second problem that the patients begin to get older and you're less favorable. So I think overall allogeneic transplantation, I know a lot of people are using it, but I think that it's getting less and less defined. There's a paper by Jacob Rowe 2 years ago in bone marrow transplantation, and they actually analyzes every study in allogeneic transplantation area, says I can't make any conclusions. So I think the field is very, very open, and I say it might change soon. One thing to add, I think autologous transplant is not considered a treatment in this disease.
Thank you.
I think you're right that in ALL, I think it's become increasingly difficult to know who is the best candidate for a transplant. The French did publish data last year that, again, measurement of minimal residual disease and MRD positivity is a strong predictor of adverse outcome, and particularly those patients may be the ones to benefit. And they've actually also then combined that with some of the high-risk adverse genetic features to come up with an oncogenetic profile, as they've called it, to try to predict who might benefit from transplant.
And then I would just point out also as an aside that beyond first remission, allogeneic transplant really offers the only realistic chance of cure. So it should be indicated in that particular setting, although the reality is most patients who relapse following an initial remission don't get to a transplant. But if they do get to a transplant or can get to a transplant, then that offers still a curative potential.
Thanks, Jeff. And that actually leads us to the question.